Thank you very much for very kind introduction. I'm grateful to the organizers and to the audience, and also Novo Nordisk, because this is actually a sponsored lecture. This is my disclosure. I've been engaged as a speaker with content development supported by Novo Nordisk, but all the contents and their accuracy is my responsibility. Novo Nordisk does not support the use of any product in a manner inconsistent with its approved labeling. Of course, we physicians make judicious changes in the recommendations and will receive some honorarium. So the topic is interesting because GLPs are very much in drugs these days. My presentation is divided into 3 portions. In the first section, I will talk about native GLP and analogs. And in the second section, I will talk about the role of GLP-1 receptor agonists in the management of type 2 diabetes. And in the last section, role of GLP-1 receptor agonists in obesity management. The first one, native GLP and analog, because time will not allow me to discuss anything in detail, but I will be available for any questions and answers later on. So the first section, you are all aware of this GLP and GIP, the incretin effect. This is the picture of our gut. Whenever we eat, the food goes to the stomach, and due to neurohumoral signaling, our neuroendocrine cells called L cells in the ileum, they secrete something which is called GLP, glucagon-like peptide, and also similar compound called GIP. And this is absorbed and comes to the circulation. And it has got some wonderful effects, amazing effects, and I will only be able to highlight some of them. First of all, it goes to the pancreas and stimulates both. It has effect on both alpha cells as well as beta cells. On beta cells, they help to secrete insulin just enough to bring down glucose to the normal level, not too much. And you know, in diabetes, alpha cells are unduly stimulated and they're producing too much glucagon, and this GLP suppresses alpha cell that the glucagon is not produced. Again, this effect is glucose dependent. And the third effect, very important and very promising, it has got effect on the beta cell health also. It modulates the apoptosis, which is programmed cell death, and they prolong their lives. You know, in diabetes, beta cells, they damage progressively. So I think there is a hope with the use of these drugs, we may be able to save them for a longer time. And the second effect is on gastric emptying. With GLP, stomach moves less and food stays in the stomach for a longer time, and we have this feeling of fullness for a longer time. And third effect, which is extremely important, is the effect on hypothalamus, brain, and it regulates our satiety. Now, you please note down that there is a difference between anorexia and satiety. Satiety is a positive feeling, a good feeling, as if you have eaten, and a reward feeling, whereas anorexia is a sick feeling. So it gives you a feeling of satiety, and that means you have taken your food. And it has got to also affect in the liver indirectly, and it inhibits glucose production in the liver. So all these, they help to control glucose and also to reduce weight. So the problem is that the GLP has got extremely fast metabolism. DPP-4 enzyme destroys our endogenous GLP within minutes. So this cannot be used for therapeutic purposes, although it has got a lot of good functions, but it cannot be used for therapeutic purposes. There are 2 possible solutions. One is to develop DPP-4 inhibitors. So by taking DPP-4 inhibitors, your endogenous GLP will stay in the body for a longer time. And the other solution is to develop GLP receptor analogs, which are very similar to natural GLP, but it is not vulnerable to the effect of DPP-4, so it stays longer. In fact, with further modification, they have made it such long functioning that it could work for maybe a week or so. So what do you think? Which approach you think is more physiological, or which more appealing? Development of DPP-4 inhibitor and preserving your very own GLP, or giving GLP analogs? Actually, there is a difference. I think one would think that the first approach is more physiological, but actually many of the effects of GLP, they come when you give in a pharmacological dose. In this side, by giving DPP-4 inhibitors, you can only preserve your own GLP, which is already reduced in type 2 diabetes. But with the pharmacological dose, you can have much higher level, maybe 10 times higher level of GLP, and you can achieve many effects like on weight, on brain, only with the GLP analogs. That is why you can expect weight loss with GLP analogs, but not with DPP-4 inhibitors. So I'm going to highlight those GLPs which are available in Pakistan. So I'm going to give you a brief comparison: semaglutide 1 milligram, liraglutide 3 milligram, and dulaglutide 1.5 milligram. First of all, the primary approval. You know, semaglutide 1 milligram is primarily indicated for the management of diabetes. By the regulatory bodies, it is approved for diabetes. Liraglutide 3 milligram preparation is approved for obesity management, and dulaglutide is also approved for diabetes management. And when you examine the effect on A1C, you can see the comparison. Semaglutide has the most robust effect on A1C. When we use liraglutide on obesity, there is probably negligible effect on A1C because their glucose is already normal. And since the effect is glucose dependent, so in non-diabetic but obese people, this liraglutide would not have any effect, but when we use it for the diabetes, it would have some effect, 1.3. But comparing three, I think, which one would you choose if you're using it for diabetes? The one which has got maximum effect on A1C, that is semaglutide. And when we're using for weight loss, liraglutide 3 milligram has the maximum weight lowering effect. You can compare the figures. With dulaglutide and with semaglutide 1 milligram, there is just 3 or 4 kilogram weight loss in 1 year. Whereas you can have more than 10 kg weight loss with the liraglutide 3 milligram. Frequency, liraglutide is to be given daily, but other two are weekly. And tolerability, all these GLPs, they have some initial side effects, but most of them, they go away, especially if you use the small dose and escalate gradually, and a motivated patient will tolerate these side effects, and within weeks, the side effect will go away. So this is how we escalate the dose. So the summary of the first section is GLP receptor agonists are highly effective therapeutic options for the diabetes as well as obesity. It is essential to select the right GLP-1 receptor agonist for the appropriate patient. So it's not that any GLP for any indication, you will have to choose the right one for the right patient. So this brings me to the second session, that is the role of GLP receptor agonists in type 2 diabetes management. You're all familiar with this picture. It's a very, very busy picture, but I'm going to highlight, magnify the relevant part, which is this one. According to ADA and ESG algorithm, if somebody is diabetic but has got atherosclerotic cardiovascular disease or is at a high risk of developing atherosclerotic cardiovascular disease, he is a right candidate for GLP receptor agonist after metformin. We don't wait for metformin to go to the maximum dose. Along with metformin, GLP receptor agonists are indicated. So indications are type 2 diabetes management, evidence-based and FDA approved. If you have diabetes and have existing atherosclerotic cardiovascular disease in any form, angina, myocardial infarction, stroke, angioplasty, any manifestation of atherosclerotic cardiovascular disease, you are eligible for GLP-1 receptor agonist, irrespective of your A1C. Your A1C may be normal. With metformin, you might have achieved normal A1C, but still you are a candidate for GLP receptor agonist therapy. And the second is those patients who have risk factor for atherosclerotic cardiovascular disease. They don't have disease yet, but they are high-risk patients. Again, irrespective of A1C, GLP receptor agonists are indicated. And third is just any patient with type 2 diabetes where you want to intensify their therapy to bring down their A1C. For example, somebody is taking 2-drug combination or 3-drug combination and still not at goal. I think he is also a candidate for GLP-1 receptor agonist for diabetes. And this indication is irrespective of their weight. Please note down, weight is not the criteria. You may be normal weight, you may be actually slightly underweight. If you qualify, if you're type 2 diabetic patient and have atherosclerotic cardiovascular disease, you are the candidate for this therapy. So how do we treat? And we start with a low dose, 0.25 milligram. This comes in a pen. You can only dial 0.25 or 0.5, and in another pen you can only dial 1. So 0.25 milligram once weekly for 4 weeks. This is just to let patient's body get used to the drug. You don't expect any therapeutic effect. Move on to 0.5 milligram, and this must be continued for 12 weeks, because then we are going to do A1C and see if it is working. If A1C is less than 7, that means we have achieved our target, and you may continue that for indefinite period of time. And of course, diabetes is a dynamic disease. You will keep following A1C. Whenever A1C goes above 7, then you will have to titrate the dosage again. And yes, this I've already said. And the second thing is you take it to the optimum level. The first one was take to the desired level, the effective level, and this is the optimum dose. The optimum effect of A1, the GLP receptor agonist, is achieved with 1 milligram. So if it is more than 7, then you push it to 1 milligram. Okay? But the second thing which I'm going to highlight, if A1C is less than 7, but you still want to push it to have the maximum optimum effect, I would increase GLP-1 receptor agonist to 1 milligram and reduce other medication if patient is already achieved his A1C. So that is how we get the maximum effect, because it has got wonderful effect. You can see this picture compared to other GLP receptor agonists. Semaglutide 1 milligram has the maximum A1C lowering effect, 1.8%, to make it one of the most potent drugs. And not only on A1C, these trials have shown that semaglutide 1 milligram has effect on A1C, weight, MACE. You know the trials, leader trial, and that was for about liraglutide, but the sustained trial has shown significant benefit in MACE 3 points, very good effect on CKD and heart failure, whether with preserved ejection fraction or reduced ejection fraction. These are the latest trials. They have shown beneficial effect of GLP on these parameters. So this is, truly speaking, an anti-diabetic drug, not just hypoglycemic, the glucose lowering therapy. It is an actually anti-diabetic drug. So the summary of this section 2 is, in view of the above evidence, semaglutide is an attractive choice for people with diabetes with or without atherosclerotic cardiovascular disease. For with, it is almost mandatory, but for without, I think when you want to intensify their therapy. Now, the third section, role of GLP receptor agonist in obesity management. So, what is the approach to the obesity? First of all, you may be lucky that somebody reports to you, already realize that he's overweight and he comes to you with weight problem. I think the management becomes simple. But most patients will come for other medical issues. I think then you must talk about their presenting symptom first, and then you suggest the possibility that there may be the weight which is behind this. Somebody comes with non-alcoholic fatty liver disease, with hyperuricemia, with diabetes, with hypertension, and you see the person is overweight, then very softly, gently, you raise the possibility that it may be the weight which is causing all these issues. And then you also acknowledge, because everybody who is overweight, I'm sure, has tried something to lower his weight and has failed. So you must acknowledge the fact that it is very hard to fight weight. And you could give your own example if you're overweight, and most of us are overweight, and you could give them your own example that I've been trying to lose weight and it is very hard. Because this is how you take patient into confidence, and then patient will listen to you. Never accuse a patient for being obese. Don't use derogatory words. Be respectful. I think use proper words. Discuss the importance of lifestyle changes in the management, and also discuss various treatment options, their pros and cons. And if patient has agreed and patient has understood the point, you could give him the prescription or arrange another meeting for obesity management. So consequences of obesity, it's not just a social issue. Weight could cause diabetes, weight could cause hypertension, osteoarthritis, high uric acid, gout, obstructive sleep apnea, PCOS in women, non-alcoholic fatty liver disease is almost a universal association of type 2 diabetes, and many cancers. So all these could happen with this obesity. What is the cause? I think everything we do, everything we have, behind that there is genes, but those genes, they modulate our hypothalamus, determine our food preferences, and that leads to positive energy balance. We eat too much, we consume very little, and that leads to obesity. So we have several interventions, and this is the point where there is an opportunity of intervention, because genes we can't do much. At least today, up to maybe in future we could edit the genes also, but up to today we can't do anything about the genes, but we can alter their effect on hypothalamus. Why can't we control weight just by will? When we do dietary restrictions, there is craving for food. And this leads to increase in the level of many hunger hormones. This ghrelin, neuropeptide Y, and agouti-related peptide and orexin. These are the hormones which are produced by the hypothalamus, and many satiety hormones which gives us satiety, they are suppressed. So by giving drugs, we can alter this, and I think nothing works unless you control the factors in the hypothalamus. You know, orlistat is a great mechanism of action, but it doesn't work. So make a smart treatment approach for obesity. Smart is something which is specific, measurable, achievable, relevant, and time-bound. Recognizing the problem is the first step, making a smart plan, second step, lifestyle changes, reducing food and increasing exercise, and pharmacotherapy, and then ultimately bariatric surgery. The pharmacotherapy is actually going to make your lifestyle changes possible, because it will control satiety. When you control your diet, you will not have that craving, uncontrollable craving. So that is how these GLP receptor agonists work. So treatment of obesity with liraglutide 3 milligram, FDA approved and EM approved. If your BMI is more than 30, you are eligible without comorbidities. And if your if your BMI is more than 27, and if you have one or two conditions which are related to weight, you are eligible. Then adolescents with more than 60 kg weight, they are also eligible, irrespective of diabetes. You may not be diabetic, you may have a little bit of diabetes. If you qualify these, I think you are eligible for GLP receptor agonist therapy, liraglutide. So titration of liraglutide, we start with 0.6 milligram for 1 week, move on to 1.2 milligram and 1.8, and then 2.4, and then 3 milligram, which is continued for indefinite period. Even for obesity, it is a long-term treatment, because obesity is a chronic disease. You will probably have to use for long term. But after 16 weeks, we reassess if the drug is working or not, and if it is not, then maybe you can stop, but otherwise you continue, and you can expect 11 kg weight loss at the end of 1 year. Benefits of treatment, all these parameters which I mentioned, they get reduced. And I think weight is the only thing we possess and is worth losing. So the summary point 3, liraglutide 3 milligram is an appealing option for individuals with obesity, as it targets the root of the problem, the hypothalamus. So I have built some questions, some FAQs with their answers, and this is the reference GPT-4. So if you want to confirm, you could ask the same question to GPT-4. How long should we continue semaglutide 1 milligram for diabetes for indefinite period? Do we have an FDA EMA approved semaglutide or liraglutide biosimilar? To date, no. Is it important to get to the optimum dose of semaglutide? Yes, but exceptions exist. Somebody may not tolerate 1 milligram. When to stop liraglutide 3 milligram for weight? Probably never, but exceptions exist. If somebody has achieved his goal weight and then can maintain his lifestyle, the new lifestyle he has adopted, then maybe you can stop it. Can we prescribe liraglutide 3 milligram OD with orlistat? Possibly yes, but there's no data because no trial has been conducted. I sometimes prescribe this combination. Is liraglutide 3 milligram FDA EMA approved for obesity management in adults and adolescents? Yes. So this is all. I think this brings me to the summary. Use of the drugs as per their approval. Semaglutide 1 milligram for diabetes, one of the most potent HbA1c lowering therapy with proven benefits on atherosclerotic cardiovascular disease. It is approved by FDA and EMA. And then liraglutide 3 milligram for obesity, robust weight lowering effect and weight-related comorbidities in adults and adolescents, again approved by FDA and EMA. So use the drugs for which they are approved. Are you using these drugs according to their approval? Think again if you're not. If you want to learn more on this topic, you can access my channel, which is free to join, or just type this word anywhere on the internet. You will be right in my channel. Thank you. Thank you, everyone, and thank you, Novo Nordisk, my sponsor.